one, go.
Good morning, Kate.
Morning.
Okay, so I'm going to deliver a session to you today. It's about Entonox therapy as a form of pain relief, and it's a training session that I normally deliver to medical students, nurses, healthcare assistants in the local hospital that I work in. Okay, so I've prepared some paperwork, some handouts, which at your leisure after the session you can read through. But to start with, I will give you, the aim of the session is to provide you with a basic knowledge and awareness of Entonox therapy, safe procedures when prescribing it, and to prepare you to be competent while supervising a patient who's using it.
Okay.
Right. I have given you, because we don't have projector facilities here, I've actually just printed the handout for you of the slides.
Okay.
I've also given you a competency assessment form, so what we will do is we will work through, at the end of the session I'm hoping that you will be able to define what Entonox is, be aware of how it's prescribed, and the importance of gaining consent from patients.
Okay.
Make you aware of how to gain indications and contraindications to the use of Entonox.
Okay.
Identify clinical procedures that you could use it for.
Okay.
You will be able to perform an initial assessment on a patient and their environment to make sure that it's safe to use. Understand how it works, how it affects the patient physiologically. Demonstrate how you can support, supervise and monitor the patient whilst they're using this self-administered drug.
Okay.
What I'm unable to give you today is the practical side of Entonox therapy because it's a drug. I'm unable to bring that to this venue in order for you to practice, but we could book another session later and then that will allow you to have a full understanding of the drug therapy. Okay, fantastic. So, have you ever had Entonox therapy?
No, I haven't, but my partner has.
Okay, so have you seen it in use?
Yes.
You have?
Yes.
And do you know any other uses that it could be used for? What did he have?
So he dislocated his knee and he used it as pain relief.
Yes.
Along with other drugs given by the A&E and ambulance staff.
Yes.
I know it can be used for childbirth. Other form pain relief, so if someone's broken an arm or a leg, or so that's all I really know.
Yes, and generally I started a project many years ago about trying to get Entonox to be used in other areas for different types of procedures. So we started off with it in accident and emergency, maternity, gynecological wards, and like the fracture clinic.
Yes.
But as I go through this, you'll see how I've been able to introduce it with training and support into other areas because it's such a brilliant form of pain relief for most patients.
Okay. Cool. Yeah.
Okay, so Entonox, the true name, the gas mix, is 50% nitrous oxide, 50% oxygen. Okay, so that will be. I'm just talking you through there.
Okay.
Yeah. Most people would call it gas and air, laughing gas, but Entonox is actually the manufacturer's name for it, so it's not its true name.
Okay.
We use BOC, I don't know if you've heard of BOC, big gas company, they call it Entonox, but if we had a patient that came from up north, they might know it as Medimix or Equinox. Okay, so the true name for this drug therapy is nitrous oxide and oxygen 50% mix, but of course that's a bit of a mouthful, so we just use the trade name. Okay. It's been in established use for many years, 45, 50 years. It's for acute pain, so not acute sharp pain like contractions when you're in labour or fractures of arms. Not for pains that are copable but go on and on for a long time.
Is it like a fast form of pain relief? Yes,
very, very fast. Yeah. It goes into the system within about 30 seconds and you'll get the full pain relief within 2 minutes.
Right.
And again, when you stop taking it, it goes out of your system very quickly. Nobody can have an allergy to it because it's in the air.
Right.
So, and it's a safe mix.
Yeah.
Yeah, okay, the patient wouldn't go unconscious with the 50-50 mix.
Right.
I always say it's for acute and short-term analgesia, but I will also say it's extremely good for distraction for phobias. So if somebody has a needle phobia and you're struggling to take blood or give injections, especially in children, there is no reason, if it's prescribed, and that's the key to this, it must always be prescribed.
Yeah.
There is no reason why you can't prescribe it for a child to distract them and allow you to insert a cannula into the hand effectively rather than being distressed.
Would it just calm them?
It would calm them.
Right.
It's distracting. Yes.
Okay.
Yeah. As we said, minimal side effects, into the system very quickly, out of the system very quickly.
Yeah.
Stored as a gas, and this is what I'm unable to show you, but we can do, I've got a picture there, you probably saw the cylinder with your partner.
Yes. Yeah.
And then it's just like a regulator that you breathe through.
Yes.
Okay.
Yeah, I've seen that.
Yeah. The cylinders are blue and white for enteroc therapy in the hospitals. Oxygen is white. This is blue and white. It's a mixture. And I always mention to nursing staff, because obviously you have community midwives going out doing home deliveries, that, and as we are getting colder winters, if the cylinder goes below -6 degrees in the boot of a car,
right.
what happens is the nitrous oxide and the oxygen splits, so therefore a patient could be purely self-administering nitrous oxide. So that would be very, very dangerous.
Right, so it has to be a certain temperature. It has to be a
certain temperature. In the hospital you never have to worry. They're kept in sheds, but there's radiators in there.
Yeah.
And there are ways, if a community midwife needed to warm it up, she could sit it in a bath of warm water.
Okay.
And then shake it afterwards.
So if it's gotten cold and
below -6
below
degrees.
-6 and it separates, you could put it in, say, like you said, a warm bath.
Yes.
Shake it up.
Yes.
How would you know it's gone back to normal?
Well, you would know by the cylinder itself, by feeling.
By the feeling.
Or you could leave it in room temperature for a couple of hours.
Right. And that's why obviously you have to be trained.
You have to be trained, absolutely, yes. I mean, the key to all of this training is the fact that you make sure the patient doesn't have a contraindication to using it, which there are very few.
And what does that mean, sorry?
That there is a medical, perhaps a reason why they shouldn't have it, which
right.
I'll tell you about in a moment.
Okay.
But they're rare.
Yeah.
And prescribed.
Yes.
By a doctor.
Yeah.
Okay. It's self-administered by the patient, so you're actually not giving them administrative in the drug. You're supporting them where they're self-administrating.
So they can take as much or as little
absolutely
as they like.
Yeah, perfect. Must be supervised by a trained professional. As we said, works within a few breaths and peaks at 2 minutes.
What do you mean by that?
So the effective pain relief would be more towards 2 minutes.
Right.
So for instance, if I was supporting somebody who's having a dressing, I would allow them to breathe before I suggested the nurse actually touch the leg.
Right.
So, you know.
Yes.
It's not a matter of they've got it in their mouth, they suck it.
And yeah.
And you start, you've got to let it get into the system.
Right. But even 2 minutes isn't long, is it really?
No, so it's very quick.
Yeah.
Okay. I'm not going to go into the physiological side other than to say it's breathed into the lungs and affects the brain and spinal column.
Okay.
It can give feelings of euphoria.
Yes.
That people just float away.
Yeah.
Yeah.
Which is calming, I suppose.
Yes, very, yeah. The uses, to me, are that you know a patient's in pain, acute pain, or is going to be in pain, i.e. addressing, removing a wound, tube,
yes, yeah.
tubing, that you're going to do a procedure that could be acutely painful to them.
Okay.
It's short-term analgesia. We have been aware when people have used it for 24 hours on a ward, and that should just not happen.
No.
I've gone towards before where they're struggling to give the patient pain relief, and you realise that they've gone through many cylinders. Straight away there's something wrong. They should have the acute pain nurse come and maybe set up a morphine pump.
Right,
Yeah.
yeah.
But also to make you aware that people can have addictions to Entonox.
Yes.
Okay, so you might have a patient that says only Entonox works.
Yeah.
So you have to be mindful if somebody wants it all the time.
Yeah. Because obviously they like the feeling
they like the feeling it gives them, yeah. It could be used on its own, or as say in labour, you use it for the sharp contractions, but you could have a controlled drug like pethidine, which relaxes your whole body, but you use the gas and air for the actual pain, painful contraction. Another way is if somebody's in the pool, so the warm water supports them, makes them comfortable, but as soon as the sharp contraction comes, they use the gas and air
to relax them.
Combination, yeah.
Okay.
Wide range of uses. There are so many uses that you can use it for. So, fracture manipulation. Somebody comes in and they've got to manipulate the bones.
Yeah.
Endoscopy.
What's that?
Okay, that's where they will put cameras into your bottom.
Right, yes, I know.
Burns dressings.
Yeah.
You've got to, that can be the painful part, is actually taking the dressing off before you clean it and redress it. Vascular procedures, dermatological procedures, you know, where people have got to come in and they've got sores on their skin.
Yeah.
Examples are, we've put it into so many new areas. It's in endoscopy. So before a patient would come in, they would have nothing if they had to go back to work, or they would have to make them comfortable, or they would have to have somebody with them. They would have, I'm sorry, I've forgotten the name, it's a sedative drug, okay, and they would have to have somebody take them home and stay with them.
Right.
With Entonox therapy, they can now use that. It's out of the system so quickly, they can just have their observations done, have a cup of tea, get back in the car and drive.
Right.
Before I started this project, a person had to wait 24 hours now before they could drive.
Yeah.
So for day case procedures, a lot of people were having the controlled drugs, thus then having to have the support from family members. Now, after 30 minutes, they can get in the car and drive, which I think is absolutely wonderful.
Yeah.
So now it can be used for day case procedures, as endoscopy, that kind of thing.
Yeah.
Yeah. The initial assessment, and really doctors don't think about Entonox a great deal. It's more teaching medical students to be aware of it, and as they go on to practice and qualify, they'll remember it.
Yeah.
And so you might have to think, I think that will benefit that patient, so I'm going to mention it to the doctor and suggest it. At the moment, we're still at that stage that the nurses have this session and then go on to suggest it to the doctor.
Okay.
So first of all, the most important thing is to check they don't have contraindication to using it. Assess the patient's ability to use it. Obviously in the hospitals now you have to have consent for everything. You have to make sure the patient understands what you're explaining to them. There is no age discrimination. I know when I was researching this as a project, some hospitals wouldn't let above 80-year-olds use it. I checked with BOC, there is absolutely no problem as long as they can hold it and understand simple instruction. It can be used for children as well.
Okay.
Preparation for use in the hospital areas is absolutely fine. It's common sense. There is no actual measurements of rooms or ventilation. You're just not going to do it in a store cupboard with the door shut for hours on end.
Yeah.
You do it in a clinic room or a ward.
Like somewhere well ventilated.
Somewhere, yeah.
Yeah.
That's right. At that point, the nurse needs to assess the need for any other analgesia. So we're going to do this dressing, but may they need some maybe cocodamol tablets after because it's going to be nipping.
Yeah.
And at that point they need to prepare that.
Okay.
You explain the procedure to them and any side effects they may experience with the Entonox. Now, you haven't experienced it, but you might have witnessed your partner.
Yeah.
People can hallucinate.
Yeah.
They can imagine strange things around them.
Yeah.
Initially, when somebody first takes it, if you've got two ways of looking at this. You've got somebody coming in acute pain. In most cases, you don't have a great deal of time to explain the side effects. They just want it there and then.
Yeah.
But if you've got somebody who's preparing to have a dressing removed, you've got that time to tell them.
Yeah.
I always say to them, though, you will always hear what I'm saying to you, because some people might be nervous of it because they feel they're losing control. Especially if they've had it before, but I explained, whatever happens, you will always hear me talking to you.
Yeah.
And you will bring them back.
Yeah.
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 So they feel safe.
Yeah.
You demonstrate, if you've got time, you let them have a little practice, because obviously if you're doing a dressing or removing a wound, tubing, it's nice that they can get a feel for how it will benefit them. If they cannot maintain, and it's not as relevant today. Before, they used to use black rubber masks for the patient to use.
Yeah.
Many years ago it was big thick black rubber masks, but now it's mouthpieces.
Yes, I've seen them.
So there shouldn't be a problem with the seal, you know.
Okay.
It's only if somebody's had facial surgery that they might struggle.
Right, okay. Yeah.
If though, however, they had, or somebody just could not get to grips with it, you don't force it, you abandon it, and then you consider some alternative pain relief.
Yeah. Yeah. That's understandable.
So during administration, we reassure the patient and allow them, sometimes initially with the acute pain the patient will overly breathe, so you've got the risk of hyperventilating. What you do is, if it's a procedure, you stop what you're doing, you get them to breathe fresh air, then you support them with their breathing. So if you feel they're going too fast, you take nice deep breaths, nice and slowly. The only time I will encourage them to breathe a little bit more rapidly is when I know, if I can see there's going to be a really, really sharp pain.
Right.
Then I will encourage them to breathe a little bit faster in order to cover that part, and then back down to nice steady breathing.
Right, okay.
You allow them to use as required throughout the procedure.
Yeah.
As a midwife, when I was a practicing midwife, I was aware that sometimes other colleagues would perhaps say, right, stop using that, because you're not concentrating, but it's all about how you support them in their breathing.
Yes.
They can still use it, you just maybe got to calm it down a little bit. You observe their level of pain, how effective it is. Side effects is very subjective. People will say, oh, it's making me feel sick, I feel sick.